So this is part 2, talking about glomerulonephritis and specific diseases. And so now we're going to talk about diseases that cause acute nephritis, or RPGN, which stands for rapidly progressive glomerulonephritis. And just to outline the spectrum here, these diseases tend to present with isolated hematuria. These diseases tend to present with a nephritic picture with or without nephrotic syndrome. And really now we're going to talk about diseases that present with an acute onset of nephritis. And when we say RPGN, what I mean is not only is it an acute GN, but also the kidney function is severely diminished, and something is occurring and it's pretty severe, and it's affecting a lot of the kidney and causing a pretty significant decline in kidney function. And of course, real life is not as cleanly delineated like this. Remember, IgA nephropathy can do almost anything. The C3GNs could certainly cause an acute nephritis. But just to make it easy for this talk, I think I'm doing it like this. But real life, remember, is a little more messier and less clean. So of the diseases that cause acute nephritis, or RPGN, you may see one of these patterns on pathology. Let's say if you did a kidney biopsy. So here we are looking at capillary loops in cross-section. And so one pattern is simple endocapillary proliferation. So in addition to mesangial cell proliferation, now we see extra inflammatory cells in the capillary loop. And so here you can see extra neutrophils that shouldn't be there. You can see here's an endothelial cell that is swollen and being activated. And also you see the podocyte here is ill. It's lost its structure, it's lost its foot processes, and it's injured. Now if this injury and inflammation is severe enough, it can lead to glomerular necrosis. And here we see a necrosis of the cells associated with this capillary loop. You can see here the endothelial cell is dying, the podocyte is dying. You can see that we've lost the basement membrane, and now there's all these extra cells outside of the capillary loop, and this would be the development of a fibrocellular crescent. So essentially what happens when there's large holes in the capillary loop, now plasma proteins, including coagulation factors and fibrin, can start depositing around the kidney, forming this fibrin matrix. And of course, inflammatory cells get recruited, so macrophages will show up, other inflammatory cells show up, and also glomerular parietal epithelial cells start dividing. And basically, outside the glomerulus, you have this sort of large mass of cells and fibrin that will grow and grow, and eventually it can kind of compress the glomerulus. And so this is in response to severe, like overwhelming glomerular injury that can be brought on by some of these diseases. So here are some of the diseases that can do this. And so lupus nephritis, remember, can do many different things, but specifically when you see endocapillary proliferation, it brings it into class 3 and class 4 lupus nephritis. Remember, we just saw mesangial proliferation alone, and that was class 2. So now we have class 3 lupus nephritis when we have endocapillary proliferation here. So on biopsy, after we stain this, we can see the full house staining of the immune deposits. And so if we see immune deposits in the subendothelial space in the mesangial area, what we're looking for is this full house staining pattern where we see everything. We see IgG, IgA, IgM, and then complement fragments, both C3 and C1q. So next, there's an entity called infection-related GN. And so I think we're using this term more often to describe the post-infectious GN, because we also see this entity while there's an active infection. So I like the term infection-related GN to describe the post-infectious and the active infectious GNs. And so in this process, you see endocapillary proliferation and maybe even crescents. But if you were to stain the tissue, you see IgG and C3. And so basically what's happening, there are some bacterial antigens and immune complexes being formed. And actually the deposits form in the subepithelial space. So you see these subepithelial humps, and this will activate the alternative complement pathway and drives the inflammatory process. Now this list is by no means complete. There are other immune complex diseases that can cause endocapillary proliferation or crescent formation. And some of these are like HIV, immune complex kidney disease, which is seen in patients with chronic HIV disease. Also, cryoglobulonemic GN, which we've mentioned before, can also cause an acute glomerulonephritis. Okay, so two more diseases that are worth mentioning, and these can both cause acute nephritis and typically can cause an RPGN, so rapid progression of the GN with glomerular necrosis and crescent formation. So one of these is anti-GBM disease, okay? And so this is where there's an antibody directed against the glomerular basement membrane. So on pathology, if you were going to stain it, what you see is linear IgG staining along the glomerular basement membrane, and so this is a big clue. Next is a disease called ANCA vasculitis, which we have mentioned before. And this is actually a spectrum of diseases, but particularly the glomerulus can be involved and can be quite rapidly insulted by the inflammation there. And so if we were going to do staining on that kidney biopsy, this is what we call the pauci-immune picture, in that there's no deposits. Remember, based on our initial video on the mechanisms of GN, it's actually an autoantibody against an autoantigen present on neutrophils. And then once those neutrophils are activated, they attack the endothelial cell and capillaries in the glomerulus. So there's no immune deposits actually embedding themselves in the glomerulus that's stimulating the inflammation. It's the neutrophils that are sort of out of control. So this helps us. This is why we do a kidney biopsy, because clinically they may all present the same way, acute nephritis or acute nephritis with rapidly worsening kidney function. But we won't really be able to tell unless we do the biopsy and we see the staining of deposits, what it looks like, what actually stains positive, and whether deposits are there or not. Remember, any of these diseases can cause the endocapillary proliferation lesion or just frank glomerular necrosis with crescent formation. It just seems that aggressive lupus nephritis tends to cause crescents, as well as anti-GBM disease and ANCA vasculitis. Crescents seem to be more popular in those diseases. So speaking of all these crescents, I did want to show an image of what it actually looks like under the microscope. So on pathology, we're looking at the glomerulus here, and so it's sort of being squeezed up a little bit. Maybe it's a little more shrunken than normal. And you can see here that there's a large fibrocellular crescent in Bowman space that it normally shouldn't be there. And so this is this mass of fibrin. Remember, that came from plasma proteins, and then there's inflammatory cells like macrophages, inflammatory cells, and parietal epithelial cells. And so this is a sign of extensive and sudden glomerular injury. And so we only see it in diseases that are typically causing nephritis and a lot of endocapillary proliferation. And so we can see this in lupus nephritis, class 3 or 4. We can see this in anti-GBM disease, ANCA vasculitis, and even IgA nephropathy. So it's a non-specific finding, but we only see it when there's severe glomerular injury. So next, and finally, I want to talk about the thrombotic microangiopathies. We sometimes say TMA for short. So this is a series of diseases that can cause acute nephritis, but the mechanism is a little different than what we've said before. In this instance, there's some sort of endothelial insult and predisposition for microthrombi formation. And so when thrombi, or these clots, form in small blood vessels, they can affect different parts of the body, but obviously if they occur in the glomerular capillaries, they can cause a glomerulonephritis. And so here is a microthrombus, there's some endothelial damage, and you can see the podocyte is sick. And so this can lead to rapid kidney dysfunction. So here's a list of some of the diseases that can cause a thrombotic microangiopathy in the kidney. So one of them is TTP. The other one is typical hemolytic uremic syndrome. And so remember, this is the disease that's seen in children who have a diarrheal illness due to some invasive bacterium that produces a toxin that actually causes the endothelial damage. There's also an atypical hemolytic uremic syndrome where it occurs sporadically or in response to some other insult, but it's actually because the patient has some problem regulating the alternative complement pathway. And then there's also antiphospholipid antibody syndrome. Remember, these patients have a tendency for thromboses, and they can also have a thrombotic microangiopathy. Also, malignant hypertension can do this, as well as scleroderma renal crisis, which occurs in patients with scleroderma. So there you go, that's a good first pass at the spectrum of glomerulonephritis. And remember, this is just a brief overview. There's always more to go into, but I think this is a good first start, especially if you're just encountering this kind of material.